Yeah, I think live has started.
Sir, started, sir. We can start the session. Sir.
Yeah, can we start the program?
Yeah. So, Jayesh,
Yes, sir.
you start the recording also now.
We started? No, just give me a
Yes,
okay,
sir.
then we will start the program.
Yes, sir. You can start now, sir. No issue.
Yeah, okay. So, a very good evening again to all the postgraduates and faculty. So today we will start a very interesting session, and I think every postgraduate has to know how to read an X-ray. Not only in exam, I think even in practice. If you know how to read an X-ray, I think half the diagnosis is made. Not half, in fact, most of the diagnosis is made by X-ray, and especially in bone tumors, most of the cases you can diagnose with X-rays. And today will be one such class where at the end of the class, definitely I'm sure you'll all be able to read the X-ray and identify the bone tumors very easily. And today we have two very senior faculty. Dr. Agniraj will be the speaker for the first session. So first he will take a class as to how to read the X-ray. That will be for around 30 to 40 minutes. And then we have around 8 to 9 PGs today. So each one of them will be given one X-ray and will be asked to read the X-ray. And Dr. Agniraj and Professor Kumar will help them how to find the diagnosis. And Dr. Agniraj is an assistant professor, a senior assistant professor in Government Kilpauk Medical College. He's got a very lot of hunger and thirst for teaching. I think he is a faculty for a lot of NEET PG courses and UG courses. So he knows exactly how to deal with his youngsters, in what way to learn, how to teach them. He uses a lot of mnemonics for them to easily remember these points. And today, I think the PGs are lucky enough to have him today as a speaker. And it will be a very interesting talk also. And Professor Kumar is a very senior person. He was a very senior assistant professor in Government Salem Medical College. Now he's an associate professor in Government Dharmapuri Medical College. An interesting fact is he has got a lot of interest towards tumor surgery. And definitely his knowledge will be very useful to the postgraduates today to understand the basics of X-ray and how to read the bone tumors. So without much delay, I hand it over to Dr. Agniraj and Professor Kumar for them to start the program. Dr. Agni, I think you can start.
Thank you, sir. Thank you for the introduction, sir. First of all, I want to thank TNOA faculties for allowing me to present this topic here. I especially want to thank my mentor, Professor Dr. Thirunaran also. Sir, Kumar sir has joined, sir. Can I start sharing the screen?
Yeah. Yes, please start. Please start.
Sir, able to see the visible, sir? Screen is visible. Can I proceed?
Yes. Your screen is visible, ma. Yes.
Okay. These are the lines taken from Campbell's operative orthopedics. Compared with any other test, conventional radiography provides more useful diagnostic information for evaluation of bone lesions. Often, the patient's age and plain radiographic findings are sufficient to arrive at a specific diagnosis. Though today's topic is radiology of bone tumors, I will be discussing only about the X-ray, how to read bone tumor X-ray, because as a postgraduate, I think X-ray is very important for you. For your level, you should be able to read the X-ray in a systematic and a stepwise manner and come to a diagnosis, or at least a differential diagnosis. Why reading a bone tumor X-ray is important? I want to say a famous quote by Renford Rees: if you take care of the little things, the big things take care of themselves. This is when all you will come across this X-ray of the tumors as a postgraduate. First, in the exam, you may get in the morning session clinicals, you may have some X-ray. You may have a tumor case, followed by that X-ray discussion will be there. Based on that, your your treatment protocol will be changing. In the afternoon session also, you are having a separate X-ray session in the Viva house. So if you are in the border in the morning, if you are not performed well, and if you are able to find the X-ray tumor borders very clearly, you can come out of that border by getting pass if you read the X-ray correctly in a systematic manner. Examiner may like you because you know how to read an tumor X-ray. So straight away we'll go to the topic. Now first of all we'll see what are the tumors, bone tumors, what are the types of tumors based on the WHO classification. We'll classify so that we'll be familiar with the tumors so that it can be easy. So the WHO classification, the types are divided into benign and malignant. Bone forming, osteoid forming tumors are, benign tumors are osteoma, osteoid osteoma, and osteoblastoma. Malignant is osteosarcoma. Cartilage forming tumors, benign tumors are osteochondroma, enchondroma, and chondroblastoma. Malignant tumors are only one chondrosarcoma. Giant cell tumor is a separate entity. It is otherwise called osteoclastoma. Giant cell tumor is a locally aggressive tumor. It is not classified as benign or malignant. It is a separate entity, locally aggressive tumor. Marrow tumors are round cell tumors. They arise from the marrow, medullary cavity. These tumors are 4 tumors. All these are malignant. They are highly aggressive tumors, are more malignant tumors. All the marrow tumors are more malignant tumors. They are 4 in number: Ewing sarcoma, multiple myeloma, lymphoma, and plasmacytoma. And vascular tumors, benign is hemangioma, malignant is angiosarcoma. Other tumors are benign tumors, neurolemoma and neurofibroma, and malignant tumors are chordoma and adamantinoma. Okay, so we'll go to the topic. Now I invite anyone, can I call Suresh Lakshmikantan to read this X-ray? Yes, Suresh, you can unmute yourself and read this X-ray. So you don't give a, yes, first I instruct you, don't give a flash diagnosis. We don't want the diagnosis. You first read the X-ray. Based on that, we can arrive at a diagnosis.
Audible, sir?
Yes, audible.
It's a plain X-ray of a skeletally mature individual.
Very good.
With a distal radius with wrist joint along with carpal bones, showing osteolytic lesion involving an epiphyseal metaphyseal junction with multiple ossifications in the within the osteolytic lesion.
Okay. Then what else you want to say? What else you want to say? So
sir, zone of sir.
Yes. So yes. So you are told the skeletal.
Comment about the transition, sir.
Yes.
I don't know how to comment about the zone of transition, sir.
Don't know. Okay. Zone of transition. You don't know whether it is narrow or wide. You don't know. Okay. Then. So there are actually there are actually only seven factors, 7 things which you go in order. You can read the X-ray properly and come to a diagnosis. Okay. So first one is age. Second one is location. These two you told. These two alone you told. Age you told skeletally mature. Location you told distal radius, epiphyseal metaphyseal location. And you told there is some ossification. It's not ossification. Yeah, they are bone septations. Other thing you left is it is an expansile lesion, not eccentric, but expansile lesion. It is a lytic lesion. You told margins are somewhat well defined. It is not ill-defined margins. And the patterns of bone destruction you told, you didn't say it, you simply said lytic. It is a geographic type of bone destruction, and there is no periosteal reaction. Matrix is clear, and there are no complications. So what is your diagnosis? Yes, Suresh. What is your diagnosis? Suresh, are you there?
Hello, sir.
What is your diagnosis, or at least differential diagnosis?
Sir, giant cell tumor, sir.
Okay, differential diagnosis. What is the closest differential diagnosis of giant cell tumor, even though it arises from metaphysis? Closest. Okay. You don't know.
I don't know, sir.
Okay. Closest differential diagnosis aneurysmal bone cyst. It arises from metaphysis, but your diagnosis is correct. Giant cell tumor is correct. So based on these factors, only these 7 things I'm going to discuss. It will be only for a half an hour class. Okay. So first age and location. What is the tumor margin or zone of transition? How is the zone of transition, whether it is narrow or wide, and what the tumor is doing to the bone, what destruction it is making, patterns of bone destruction. There are 3 types. We will see one by one: geographic, moth-eaten, and permeative. And what the bone does to the tumor, that is periosteal reaction. There are in that there are 2 types: continuous or solid. Another one is interrupted. Okay. 6th one is matrix, whether it is a osteoid forming bone tumor or chondroid forming bone tumor, mainly for sclerotic bone lesions, and whether any complications, like whether there are any cortical breakdown is there, or soft tissue extension is there, or very important pathological fracture is there. These are the 7 things. If you are going to, if anything is present, you will read in this order. The X-ray you can read in this order. We will go one by one. Okay. So age, why it is so important? The most common malignancy, the most common primary malignant bone tumor of first decade is Ewing sarcoma. Second decade it is osteosarcoma. The most common age group is 5 to 15 years or 20 years. So I'm talking about primary osteosarcoma. The most common malignant bone tumor of long bones is osteosarcoma. It is common in the second decade. First decade it is Ewing sarcoma. Third decade it is giant cell tumor. You can remember easily, giant cell tumor has 3 letters, 1, 2, 3. So it is common in third decade. Easily you can remember. Fourth decade, more than 40 years, or fifth decade or elderly, the commonest malignancy or metastasis is the most common malignancy of bone. Generally speaking, most common malignancy of bone is metastasis, and another tumor is multiple myeloma. You can also add chondrosarcoma here. Okay, these are the tumors based on the age. Based on the sex, if you want to know, all bone tumors are common in male, except 2. The 2 tumors are giant cell tumor and fibrous dysplasia. The only 2 bone tumors which are slightly more common in females are giant cell tumor and fibrous dysplasia. That also you can easily remember. Giant cell tumor starts with the G for girls, giant cell tumor, and F for females, fibrous dysplasia. And another tumor which resembles closely to giant cell tumor, which I told, aneurysmal bone cyst, it is also slightly more common in females. Only these 3 tumors sex-wise common in females. All other bone tumors are common in males. Okay. So next we will go to the location. Location in longitudinal plane, you should know whether it is located in the epiphysis, metaphysis, or diaphysis. So I'll give mnemonic for all these 3. Epiphysis, the mnemonic is ECG. E stands for epiphysis. C stands for 2 C's are there. One is chondroblastoma, other one is clear cell chondrosarcoma. G stands for giant cell tumor. So epiphyseal tumor before physeal closure. In the first decade or second decade, it is chondroblastoma. Epiphyseal tumor after physeal closure, around 30 years, 20 to 40 years, is giant cell tumor. So chondrosarcoma, except chondrosarcoma is more common in the metaphysis. Only one type of chondrosarcoma, clear cell chondrosarcoma alone, is common in the epiphysis. Only these 3 tumors arise from the epiphysis. And one point about giant cell tumor arises from epiphysis, but later on its location is epiphysiometaphyseal. It does not, it grows, the tumor grows from the epiphysis to metaphysis. You can remember like that. It arises from epiphysis after physeal closure, but the location is epiphysiometaphyseal. Okay. So what are the tumors arising from metaphysis? The mnemonic is Busov. You can remember all the most common tumors. How to say? Most common benign bone tumor is osteochondroma. Most common primary malignant bone tumor of bone, long bones, is osteosarcoma. Most common bone tumor arising from hand is enchondroma. And both bone cysts, both simple bone cyst and aneurysmal bone cyst. Other one is chondrosarcoma. Next one is fibrous cortical defect. All these tumors arises from the metaphysis most commonly. Okay. So bone cyst, osteochondroma, osteosarcoma, chondrosarcoma, enchondroma, and fibrous cortical defect arises from metaphysis. And what are the tumors arising from diaphysis? Okay. The mnemonic is DOMSA. DOMESA. D stands for diaphysis, O stands for osteiod osteoma, M stands for multiple myeloma, E stands for Ewing sarcoma, S for secondaries, and A for adamantinoma. I'll repeat. It is DOMSA, D for diaphysis, osteiod osteoma, multiple myeloma, Ewing sarcoma, secondaries, and adamantinoma. Among this, you should never forget osteiod osteoma and Ewing sarcoma. Osteiod osteoma is the most common true benign bone tumor. It arises from femur diaphysis. Ewing sarcoma, most common primary malignant bone tumor in the first decade. It also arises, most common site is femur diaphysis. Okay, so these are the tumors arising based on the location in the longitudinal plane. So we will summarize easily in this diagram. This is a very important diagram. So epiphysis, ECG, E for epiphysis, C for chondroblastoma, G for giant cell tumor. If you carefully look at this picture, this is the physeal bar. So the epiphysis, the giant cell tumor is arising from the epiphysis, and it is also occupying the metaphysis. And you see here, we are jumping to metaphysis. Metaphysis, I told it is BOOSF. B for bone cysts, osteochondroma. B for bone cyst, O for osteochondroma, another O for osteosarcoma. C for chondrosarcoma is not here. E for enchondroma, and bone cyst. You see aneurysmal bone cyst. If you remember, if you see carefully, GCT, aneurysmal bone cyst, both are resembling same. Both will be having giant cells. Closest differential diagnosis of GCT is aneurysmal bone cyst. You should never forget. And coming to diaphysis, D, O, osteiod osteoma, M for myeloma, multiple myeloma, E for Ewing sarcoma, S for secondaries, and A for adamantinoma. So these are the tumors based on the longitudinal location. Coming to the tumors in the transverse plane. So we divide this into 4 categories: centrally located, eccentrically located, cortical, and parosteal or parosteal. Okay. So what are the centrally located tumors? Centrally located tumors are simple bone cyst, enchondroma, and fibrous dysplasia. These are also expansile lytic lesion. Both central and eccentric, we are speaking about lytic lesion alone. Okay, lytic lesion. Centrally located tumors, I will repeat: simple bone cyst, enchondroma, and fibrous dysplasia. Eccentric location, these 3 tumors you should never forget. I told GCT, ABC. Whenever GCT is there, ABC will be along with that. Other one is non-ossifying fibroma. These are the eccentric. What do you mean by eccentric, and what do you mean by central? Centrally located tumors means if you draw the middle of the tibia, you divide tibia into 2 halves. The centrally located tumors will will occupy both sides equally. That is centrally located. Eccentric means it will be more on one side alone. That is the eccentric location. You should understand that meaning. So you can remember easily the eccentric expansile lytic lesion. You can remember the mnemonic NAG. Nagam padam edukum. Adu mari NAG expands. So non-ossifying fibroma, giant cell aneurysmal bone cyst, and giant cell tumor. Other cortical tumor, the tumor arising from cortex. This is a sclerotic lesion, is osteiod osteoma. And parosteal, you should remember osteochondroma and parosteal osteosarcoma. So central and eccentric are lytic lesion, cortical and parosteal are sclerotic lesion. That also I will give the mnemonic. So this we will go through fast. This is the most commonest site of the tumors. Osteochondroma, most common site is lower end of femur. Osteosarcoma, lower end of femur. Giant cell tumor, lower end of femur. We are talking about the first most common site. You can remember around the knee joint, lower end of femur, it will be followed by upper end of tibia. So around the knee joint, you can remember osteochondroma, osteosarcoma, and giant cell tumor. Osteiod osteoma, femur diaphysis, as well as Ewing sarcoma, femur diaphysis. And bone cyst, simple bone cyst, most common site is upper end of humerus. Aneurysmal bone cyst, lower limb metaphysis, tibia more common than femur. Okay. So multiple myeloma, most common site is lumbar vertebra. Metastasis, most common site is thoracic vertebra. Most common metastasis causing bone secondaries. In females, it is breast carcinoma. In males, it is lung carcinoma. Okay. Enchondroma, as I told you, it is more common in the hand. Adamantinoma is common in the tibia. So you should remember this also while reading the tumor X-ray. So coming to the third point, we have finished the age and location. Next important one is tumor margin or border or zone of transition. So margins, tumor margin is the most reliable indicator of benign versus malignant lesion. So what are the tumor margins? Only two: well-defined and ill-defined. Simple. Okay, well-defined and ill-defined. So well-defined. What do you mean by well-defined? So this is eccentrically located lytic lesion. So how to read this? Eccentrically located osteolytic lesion in the metaphysis of the distal tibia of a skeletally immature patient. Physis is visible, skeletally immature patient. Okay, with the rim of sclerosis around it. Rim of sclerosis, the diagnosis is non-ossifying fibroma. So what do you mean by border is well defined? So the transitional area is narrow. What do you mean by transitional area? So this is the lytic lesion, this is the normal bone. So in between this, if you want to draw the margins, you can draw with a fine point pen. If you take a pen and mark, you can easily mark the margin. So it is well-defined lesion. Sclerosis, maybe it is a sclerosis. So if it is a well-defined margin, it denotes benign lesion. Simple. It denotes benign lesion. So if it is a wide border, so if you see from long, you may not what to say find any malignancy in this bone. It may, but actually it is leukemia arising from the marrow cavity. The border is now very, very poorly defined. You are not able to identify the border. Then there is some periosteal reaction is there. So transitional area is wide. What do you mean by transitional area is wide? You cannot delineate the tumor mass from the normal tissue. It is very difficult to differentiate. Okay. So that is wide border, or border is ill-defined border, or transitional area is wide. Okay. We have finished three things, still four more things. Coming to the patterns of bone destruction. So I told you what the tumor is doing to the bone. It can cause lysis. So there are three types: geographic destruction, moth-eaten destruction, and perimetrial destruction with respect to the lytic lesion. With respect to the sclerotic lesion, it is sclerotic. Okay, sclerotic lesion, that's all. So first we'll finish what are the differential diagnosis for the lytic bone lesions and the differential diagnosis for the sclerotic bone neoplasms. So DD for lytic bone lesions, I think TNOA first teaching program, it was by Professor Devada sir from Madurai. He gave this mnemonic. It is also given in all textbooks. Okay, so they conducted the DNB examination, final examination based on that tumor OSCE. So in that they have asked what is DD for lytic bone lesions. It is very, very important. The mnemonic is fog machines. So we'll go through one by one. What is fog machines? F for fibrous dysplasia and fibrous cortical defect. O is osteoblastoma. Osteoblastoma is a benign tumor arising from the posterior elements of the spine. Okay, it is a big osteoid osteoma. It is a lytic lesion. And the third thing is giant cell tumor. We have studied giant cell tumor is a expansile eccentric lytic lesion. So once giant cell tumor is there, you can see ABC will come, and other metastasis in old age, and myeloma, multiple myeloma will produce multiple punched out lytic lesion, and chondroblastoma and chondromyxoid fibroma and enchondroma. So whenever you say these chondrogenic tumors will appear as lytic lesion. In the lytic lesion, chondro means cartilage. In the lytic lesion, some cartilage forming will be seen as some white color, sclerotic lesion. The lytic lesion, sclerotic dots will be there. That is the characteristic features of all chondrogenic tumors. So chondroblastoma, chondromyxoid fibroma, and enchondroma, you should remember. Other thing, hyperparathyroidism, otherwise called brown tumor. Even infection can produce lytic lesion and bone infarction. Other one is non-ossifying fibroma. So you can remember this easily. NAG expands, I told, NAG. So three things are here. And all the chondrogenic tumors, chondroblastoma, chondromyxofibroma, and enchondroma, and simple bone cyst. The other tumor is eosinophilic granuloma. These are the differential diagnosis for lytic bone tumors. Coming to the sclerotic lesions. Sclerotic lesions, only two matrix producing tumors, osteoid matrix and chondroid matrix. Osteoid matrix, you can two tumors are there, osteoid osteoma and osteosarcoma. Chondroid, osteochondroma, enchondroma, and chondrosarcoma. So enchondroma can cause both lytic lesion with lytic lesion, and it can also present as fully sclerotic lesion. You should remember that. Chondrosarcoma and osteochondroma are chondrogenic producing sclerotic lesion. Okay. So the mnemonic for lytic, DD for lytic bone lesion is fog machines. So coming to the patterns of bone destruction, there are three types, as I told you. Geographic. Geographic means it is a well-defined lesion. The zone of transition is narrow. That means it is a benign lesion. So there is one classification like Lordvik classification, like 1A, 1B, 1C. I am not going into detail. If you remember that geographic means it is a benign process, that is enough for now. Okay. So it is a well-defined lesion. That it is a well-defined lesion with the rim of sclerosis. Sclerosis may be present or not present. So you can draw the border. Well-defined lesion. Zone of transition is narrow. Benign lesion. So examples. This is a case of non-ossific fibroma, chondromyxoid fibroma, and eosinophilic granuloma will produce geographic type of lesions. This is the DD for this X-ray. So next, going to moth-eaten. What do you mean by moth-eaten? Moth-eaten will be like this. Like this. Okay, it is like a punched out lesion. Okay, it is a less well-defined lesion. The areas of destruction with ragged borders. It can probably a malignant lesion. It can be a aggressive lesion, probably a malignant lesion, more than benign. So malignancy is increasing from geographic to moth-eaten. So this is the example. There is some moth-eaten lytic lesion. If you carefully see, some lytic lesion present in the diaphysis of the humerus. Diagnosis Ewing sarcoma. So moth-eaten differential diagnosis, the tumors are multiple myeloma, metastasis, lymphoma, and Ewing sarcoma. Among these, multiple myeloma, lymphoma, and Ewing sarcoma are all called marrow tumors or round cell lesions. So next, coming to permeative. Permeative means it is higher rate of malignancy. Higher rate of malignancy. The borders are very, very ill-defined, wide zone of transition. Okay. So it is an aggressive malignant lesion. So lesion will be like this. So this is a case of Ewing sarcoma. The differential diagnosis, same. What to say, that round cell lesions, marrow tumors are highly malignant bone tumors. Ewing sarcoma, myeloma, lymphoma, and leukemia. So coming to the periosteal reaction. Now what the bone is doing to the tumor. So if for any bone tumor, there will be some periosteal reaction. The bone will respond in the form of periosteal reaction. You should remember, periosteal reaction is not only not specific for any bone tumor. Periosteal reaction even you can see in osteomyelitis infection. You can see periosteal reaction. Okay, even in fracture, callus, it is a periosteal reaction. So there are two types: benign and malignant or aggressive type. So in benign, it can be none, no periosteal reaction, and periosteal reaction can be in the benign tumors. Periosteal reaction can be no periosteal reaction, nil periosteal reaction, or solid. Solid means it is continuous, uninterrupted, thickened cortex. Example for this is osteoid osteoma. Okay, and aggressive tumors, aggressive periosteal reaction or malignant periosteal reaction. There are three types. Here, the periosteal reaction is discontinuous, interrupted. All are same, discontinuous, interrupted. There are three types. Onion peel. One is onion peel or lamellated, multi-lamellated. Onion peel. Next one is sunburst. So here the periosteal reaction, the spicules, it is speculated. The spicules are perpendicular to the cortex of the bone. The spicules are perpendicular to the cortex of the bone. That is called sunburst appearance or hair on end appearance. Okay. Next one is Codman's triangle. Codman's triangle is the elevation of the periosteum. So the tumor from the medulla, it is breaching the cortex and coming out, and it is elevating the periosteum. This periosteum this is nothing but a new bone. New bone is forming. This triangle is called Codman's triangle. So I will explain one by one. So periosteal reaction, solid means benign. It can also seen in infection. Infection, you can get any type of periosteal reaction. If it is a chronic osteomyelitis, even in chronic osteomyelitis, you can get Codman's triangle also. Okay. So the periosteal reaction is a type of periosteitis. Okay. So it is benign or solid. Lamellated or onion peel. What is that? It is alternating area of loose sclerosis is the lucency. Sclerosis lucency. That is called onion peel. And spiculated or sunburst appearance. Here the spicules are perpendicular to the cortex of the bone, and this is Codman's triangle. Okay. So the range is increasing. Benign, aggressive. It is very aggressive. So example for solid periosteal reaction. I will call Jenny Jose to say the diagnosis for this solid periosteal reaction. What she told now. So I want whether they are attending.
Sir, good evening, sir.
Yes.
Diagnosis osteoid osteomyelitis, sir. Sir, it is mature skeleton, sir. Location the epiphysis, sir. Sorry, in the metaphysis diaphysis junction, sir.
Okay, accepted. Okay.
Then the zone of transition is well defined, sir.
Okay.
I mean, narrow zone of transition, and the pattern of bone destruction is so geographic patterns are well defined.
Okay. Okay. Thank you. So
And solid type of periosteal reaction, sir.
Yes, solid type of periosteal reaction. So this is the
nidus.
It is actually not geographic. You not say it is a sclerotic lesion with a lytic lesion inside. Our lysis surrounded by sclerosis. The lysis is the nidus. Nidus is the most characteristic feature of osteoid. Okay, very good. Then we will call Veeramani. Veeramani, you say the diagnosis for this, or you read the X-ray. So we should say what are the things you should say. I will repeat. You should say age, location, border, zone of border or zone of transition, and periosteal type of lesion, periosteal reaction. Sixth one is you have to say Veeramani, come on. Yes, Veeramani, are you there? Then we will call Gautam. Gautam.
Good evening, sir. I am audible.
Audible.
Sir, this X-ray showing humerus, skeletally immature. So it's definitely a second decade. Skeletally immature patient.
Can be gastric also. Okay.
Location of the lesions it's intramedullary cell. So and periosteal reaction is like onion peel. Onion peel is most commonly Ewing sarcomas.
Okay, border.
Sir, border is ill-defined, sir.
Okay, type of lesion. I told you three things: geographic, MOTH-EATEN, permeative.
Is permeative, sir.
Okay. So it is now. This is called onion peel appearance. It is seen in Ewing sarcoma. It can also be seen in any chronic malignant bone tumors, even osteosarcoma. So this is sunburst. This everyone will say. The sunburst appearance, most characteristic, not most. It is not a characteristic of osteosarcoma. It is seen in osteosarcoma. Okay, it's not the pathognomic feature of osteosarcoma. You should also remember that. Okay, so this is Codman's triangle. As I told you, the advancing tumor margin destroys the periosteum. So it, as a response, new bone is formed. That is called the Codman's triangle. It is seen in osteosarcoma, Ewing sarcoma, and even chronic osteomyelitis you can add. In infection, chronic osteomyelitis also you can get Codman's triangle. So coming to the last two things, matrix. So what is the matrix? Matrix is the internal extracellular tissue. It is the tissue of the tumor. Okay, it is of three types. So I told you lesions are lytic lesion and sclerotic lesion. So if it is a lytic lesion, the matrix is filled with the soft tissue. Like for example, aneurysmal bone cyst, if you take, it is filled with blood. Giant cell tumor, cystic fluid or soft tissue. So clear matrix means you see in lytic lesion, it is a clear matrix or soft tissue matrix. So chondroid matrix you will see in chondroblastic tumors like enchondroma and chondrosarcoma, even in osteochondroma. Osteoid matrix you will see in bone forming tumors like osteoid osteoma and osteosarcoma. So osteosarcoma you can get both lytic and sclerotic lesion based on the subtypes. Okay, so we will see one by one. Clear matrix, we have finished lytic lesion. So coming to this is the clear matrix. Okay, so chondroid matrix, there are three types: stippled, flocculent, ring and dark. Okay, it is the malignancy, the rate of malignancy is benign, more malignant. It is going like that. Okay, so stippled, this is a case of enchondroma, stippled calcification, flocculent classification, ring and dark classification. Okay, so these both two are for this X-ray you can say differential diagnosis enchondroma or chondrosarcoma. Enchondroma also can change to chondrosarcoma. This is ring and dark classification is seen in chondrosarcoma. So these are the chondroid matrix producing tumors. And osteoid matrix, there are three types: solid, cloud-like, and ivory-like. So solid, we have seen, now only we saw osteoid osteoma is an example for solid osteoid matrix. Okay. So these are all, these three are findings of different types of osteosarcoma. This is the parosteal osteosarcoma. Parosteal osteosarcoma, most commonest location is posterior aspect of the femur, posterior aspect of the distal femur. Okay, here you see cloud-like opacities. So bone forming tumors causes osteoid matrix, cartilage forming tumors forms chondroid matrix. So coming to the last thing, we should know the complications like cortical erosion, pathological fracture, and soft tissue extension. So cortical erosion is a feature of highly malignant bone tumor. So first tumor is osteosarcoma. Osteosarcoma, it can also be Ewing sarcoma. We can give only differential diagnosis. It is a skeletally immature patient. Second one is Ewing sarcoma. So these are the examples of the malignant tumors producing cortical erosion and pathological fracture. So now I will call Vishal. Vishal, can you read this X-ray and say the diagnosis?
Good evening, sir.
Good evening.
Sir, this is X-ray.
So I'll give the points. All the 7 points you should follow. All the 7 points you should say.
Okay, sir. Sir, this is plain X-ray of a skeletally immature individual showing proximal humerus.
Okay.
With lytic lesion in the diaphysial-metaphysial junction with well-defined borders and periosteal reaction with fallen leaf sign, which indicates pathological fracture. It's a unicameral bone cyst of the proximal humerus diaphysial areas.
Okay, I think you have told all the things, Kartik. So you should also say it is a benign tumor. That also you can say, since the borders are well defined. Based on that, it is a benign tumor, most probably unicameral bone cyst or simple bone cyst. It's this fallen fragment sign is a pathognomic feature of simple bone cyst. You should never forget. If it is there, it is only simple bone cyst or unicameral bone cyst. So some soft tissue extension. This is an example for soft tissue extension. This is a case of lymphoma. Okay. So I'll fastly say what are the things you should say. Fastly we'll revise in 5 minutes. For latecomers also it will be useful. So only 7 factors you are going to see when there is a bone tumor, when you are going to see a bone tumor X-ray. First one is age. According to age, first decade Ewing sarcoma, second decade osteosarcoma, more common than Ewing sarcoma, third decade giant cell tumor, fourth decade metastasis, multiple myeloma, chondrosarcoma. Location, it is whether epiphysis, metaphysis, or diaphysis. Epiphysis pneumonic is ECG, metaphysis pneumonic is Busev, diaphysis pneumonic is DOMSA. Then location in the transverse plane, it can be centrally located lytic lesion like simple bone cyst, enchondroma, and fibrous dysplasia, or eccentric expansile lytic lesion like non-ossifying fibroma, aneurysmal bone cyst, and giant cell tumor. Sclerotic 2 areas, cortical osteoid osteoma, parosteal osteochondroma, and parosteal osteosarcoma. This is the most common site of the tumor. Tumor margin, there are 2 types, well-defined margin and ill-defined margin. Well-defined margin is transitional area is zone of transition is narrow. Here zone of transition is wide. Patterns of bone destruction in lytic lesions, there are 3 patterns: geographic, moth-eaten, and permeative. Differential diagnosis for lytic bone lesion, the mnemonic is fog machines. So this is an example for geographic lesion, non-ossifying fibroma. Moth-eaten example, Ewing sarcoma. Permeative example, Ewing sarcoma. So if it is permeative, it denotes more malignant. If it is geographic, it can be a benign tumor. Moth-eaten is aggressive bone tumor. So periosteal reaction, there are 2 types: benign or solid or uninterrupted or continuous. All are same. Malignant, it is interrupted, discontinuous, aggressive pattern. So there are 3 types: lamellated or onion peel appearance, sunburst appearance, and Codman's triangle. All these example you know. So matrix, there are lytic lesion produces clear matrix or soft tissue matrix. Sclerotic lesions produces 2 types: chondroid matrix and osteoid matrix. Chondroid matrix, there are 3 types: stippled, flocculent, and ring and arc. Example for stippled is enchondroma. Flocculent and ring and arc, both enchondroma and chondrosarcoma you can say. And osteoid matrix, solid, cloud-like, and ivory-like. Examples are osteoid osteoma and osteosarcoma. So complications you should mention. If there is complication, you can mention like cortical erosion, pathological fracture, or soft tissue extension. So the take-home message: the difference between benign lesion and malignant lesion. So what is that? So first point, this is age is skeletally immature patient. Location, you can say it is tibia, metaphysis. Third thing, what is the zone of transition? Well-defined lesion. It is a well-defined, border is well-defined, border is ill-defined. Okay, zone of transition is narrow, zone of transition is wide. This is the age, location. Third point is pattern of border. Third is border. Fourth one is whether it is a geographic or type of patterns of bone destruction. Fourth point is geographic bone destruction. Here it can be moth-eaten and permeative. Malignant, it can be moth-eaten or permeative. Fifth one is periosteal reaction. Here it is solid periosteal reaction. Here it is interrupted periosteal reaction. Here it is interrupted periosteal reaction. And matrix is not shown here. So matrix, whether it is chondrogen, lytic, clear matrix, or chondroid matrix, or osteoid matrix, you should mention. Matrix is the 6th one. 7th one, complications like cortical breach, lack of soft tissue mass, soft tissue mass. These are the things you should remember. I have finished my topic. Hope this class was useful. Now we can start the OSCE. So we can call
Agni, sir, Professor Kumar sir's comments on this, sir. Kumar sir.
Sir, good evening. Agniraj covered all of the main features of radiological of the tumors. He presented very nicely, sir. Very useful to the students. Okay, sir. I will discuss during the case presentation, sir.
Okay, sir. Thank you, sir. Thank you.
Okay.
So first
Agni, continue.
OSCE, anyone? Okay, anyone wants to volunteer, you can unmute and say your name. I will put the OSCE among the 8 or 9. You volunteer yourself.
Veeramani raised his hand. அவனை unmute பண்ணிடுங்க. You think you want?
Okay, we'll start with the Veeramani, sir. Veeramani, you can start. Sorry.
Ramesh, you have to unmute Veeramani.
Veeramani, no?
Veeramani, Dr. Veeramani, yes.
This is the first OSCE. You can start reading the X-ray. So some questions will be based on the diagnosis. I will ask. I'll put some questions for OSCE pattern.
Dr. Veeramani, you are unmuted. You can talk. Again, he is muted.
இல்ல அவர் நம்பர் மியூட்டட்ல தான் இருக்கு.
Yes, I'm there.
No.
Unmuted, bro.
Sir, good evening, sir.
Yeah.
வந்துட்டு sir.
உங்க வீடியோ ஆன் பண்ணுங்கப்பா. See, all the PGs, you on your video also.
Those who are answering, please put on your video.
Sir, good evening, sir.
Good evening.
Sir, it is a plain X-ray of showing the knee joint with the distal femur and proximal tibia and fibula. It's a skeletally mature individual with well-defined osteolytic lesions with periosteal reaction in the diaphysial area of the proximal tibia, sir.
Yes, you repeat it. Go slowly. The one finding what you told is wrong.
Sir, it's a osteolytic lesion in the metaphyseal area of the proximal tibia with well-defined border.
You want to say this as a skeletally mature or immature? The physis is still visible. You see here the physis is visible, here visible, here.
Skeletally immature, sir.
So it can be around. Okay, I don't want to say the age group. That you have to find out. Okay. So first point, age is skeletally immature. Location, what is that you want to comment?
Sir, in metaphyseal.
Okay. Metaphysis of the
proximal tibia.
Proximal tibia. Okay. Border.
Sir, border, well-defined border, sir.
Okay. Pattern of bone destruction.
Sir, lytic lesions. Lytic lesions.
In lytic lesion, what is the pattern? What type? There are 3
sir,
types.
Geographic pattern, sir.
Geographic pattern. Okay. So next one is periosteal reaction. Is there any periosteal reaction seen or not?
Yes, sir. Periosteal reaction is there, sir.
In which view you are seeing periosteal reaction?
Sir, in lateral view, seeing periosteal reaction more clearly.
Okay. Whether it is centrally located or eccentrically located, that you didn't mention.
Sorry, it's eccentrically located.
Eccentrically located, expansile, lytic lesion in the metaphysis of the upper tibia, geographic type of bone destruction with well-defined border, with some periosteal reaction seen in the posterior aspect of the lesion. And matrix, what do you want to say about the matrix? Matrix is?
Sir, osteoid matrix. Sir.
So why you want to say as osteoid matrix? So you should have come to the diagnosis. Why you say osteoid matrix? I told matrix there are 3 types: clear matrix in lytic lesion, osteoid matrix, and chondroid matrix in sclerotic matrix. Sclerotic lesion. So here it is a lytic lesion. So the matrix is
clear matrix.
Clear. Okay. Even there is no bony septations also not seen. So we have finished. Any complications like pathological fracture or cortical breach or soft tissue extension, able to appreciate or not?
Sir, able to appreciate cortical breach in lateral view of the proximal tibia. Sir.
Okay. Lateral view, there is some cortical breach accepted. So what is your diagnosis, or you can give differential diagnosis also? So first diagnosis, what do you want to say?
Sir, simple bone cyst, sir.
Is it a common stage for that?
So it's not commonplace, but benign lesion with you.
Veeramani, you please carefully you go through what all you have said. Diagnosis is in what you have said. Very simple, very what to say. It is in the all the findings are told correctly. Simple bone cyst cannot be the first diagnosis. I cannot accept that as the first diagnosis. Yes, you try. Any other answer?
Any other diagnosis? Lytic lesions. He told the mnemonics are. What is the mnemonic? He told, sir. The B.
So if you apply that mnemonic, you can easily arrive the diagnosis.
Mnemonic is for the diagnosis, differential diagnosis of metaphysical region, eccentric.
Yes, come on, Veermani. You have to commit the answer. So actually, this is a repeat X-ray. This is not a new X-ray. This X-ray was taken from the first class of TNOA PG teaching. Professor Devada sir put this X-ray. I asked the same X-ray. This was the X-ray given for the DNB examination last year. Yes, Veeramani, you say
sir, aneurysmal bone cyst.
Okay. So I told it is eccentric expansion lytic lesion. So the mnemonic is snag. So all the three things you can say, even though the location is favors aneurysmal bone cyst. Okay. What is the age group affected? So the diagnosis aneurysmal bone cyst accepted. Sir, you want to add any diagnosis, sir? Kumar, sir?
Most likely because the eccentric lesion, you got to think in terms of giant cell tumor or aneurysmal bone cyst, and so here the aneurysm mostly fits into the aneurysmal bone cyst. It's eccentric in both AP and lateral view. There is no obvious pathological fractures nearing epiphyseal fusion age. So a second decade, at the end of second decade, or maybe aneurysmal bone cyst may be the diagnosis.
Also, I want to mention in the there was another session PG teaching. It was a bone tumor session by Dr. Professor Balachandran sir and Professor Sundar sir. He told for aneurysmal bone cyst, telangiectatic osteosarcoma is one of the important differential diagnosis. Telangiectatic osteosarcoma, PGs you should remember that also. It is a lytic type of lesion. It is a very, very aggressive bone tumor. Okay. Veeramani, what is the age group? We are talking about aneurysmal bone cyst. What is the age group and sex affected? Most common sex affected.
Sir, males are commonly affected, sir.
Male.
Yes, sir.
Oh, okay, that is wrong. Okay, age group.
Sir, second decade, sir.
Second decade. Okay, in Campbell it is given. You go and refer Campbell, aneurysmal bone cyst, there is slight female preponderance. I told only 3 tumors. Giant cell tumor, G for girls. I told giant cell, whenever you say giant cell tumor, aneurysmal bone cyst will come together.
Okay.
So it is females. Okay. What is the MRI finding of aneurysmal bone cyst? Any specific named finding? You know or don't know?
Sir, don't know, sir.
Okay, it is called a double density fluid level or fluid level. Double density fluid level. I'll show the MRI. Okay, what is the treatment for aneurysmal bone cyst? Treatment means you should say the treatment of choice for this X-ray.
Sir, extended curettage.
Okay, then.
Sir, with the embolization if needed, sir. If any arterial bleed embolization.
Okay, the treatment is not complete.
When will you do the embolization? Before or after the curettage?
Sir, before the curettage.
Okay. Before curettage, we'll shrink what are the advantages?
Tumor size, and then we'll do a extended curettage, sir.
Okay. What are the advantages of? What are the other advantages of embolization?
So to reduce the intraoperative bleeding also, sir.
Okay. Decrease the size
and reduce the recurrence rate also, sir.
Okay.
Okay, extended curettage, preoperative embolization. The treatment is you are removing so much of bone here. You are going to leave the cavity, or what you are going to what then you should do after doing extended curettage?
With cement augmentation or with bone croppings.
Okay. Advantages of cement, sir? What is the advantage of cement over bone graft?
The cement will reduce the recurrence rate, sir. It is easy to differentiate recurrence rate. Bone grafting is used difficult to differentiate recurrence tumor recurrence. If bone cement is used, it's very easy to differentiate bone recurrence.
Oh,
Okay, right. Then
Okay.
disadvantage, that is the advantage of bone graft. Disadvantage of bone cement, which is an advantage of bone graft.
Sir?
What is the disadvantage of bone cement, which becomes the advantage of bone graft?
Sir, it produces thermal reaction and reduce the cartilage damage, and if it is near to the joint, it produce more damage to the joint cartilage and restrict the function, sir.
Good.
Okay, good. Okay, then advantage of bone graft.
Bone graft.
Sir, bone graft, the cartilage will be preserved and the joint mobility and movement will be preserved compared to bone cementing techniques.
So bone grafting, I think you can immediate weight bearing is possible. That is
Yes,
the advantage. Okay. So Veeramani, what is extended curettage? What is it? How is it different from curettage? And what is it? What is that extended curettage? Like if you say no, don't know.
Any adjuvants like thing?
Like if you say you don't know the answer, I will ask some other PG.
Sir, curettage curettage with tumor margins with around surrounding normal bones also curettage, sir.
What do you mean by that? I don't understand. You are
Sir,
doing curettage.
not only the tumors and tumor margins, along with that the normal bone margins also curetted.
Okay, that is not correct. That is not the correct answer. We will ask somebody. Salman Khan, you know what is a extended curettage?
Good evening, sir. Sir, extended curettage is after curettage into the cavity we put liquid nitrogen or bone cement, which can cause thermal necrosis of the surrounding tissue. Which
liquid nitrogen, okay. Then what is that bones? Okay, PMMA. Okay, right. Okay, continue. Okay, then.
Yes, sir.
So why you are using that adjuvant? What is the advantage? What is that? Why you should use that adjuvant? What is the necessity?
It can't cause a thermal necrosis of surrounding tissue. It might contain the tumor cells.
Oh, so what?
We can prevent recurrence.
Yes, very good. That is the answer. So curettage, if you do, recurrence rate is more common for tumors like giant cell tumor and aneurysmal bone cyst. Okay, recurrence is very high rate of recurrence. So for that only we are doing extended curettage. What is the best adjuvant used? What is the most commonest adjuvant used? The adjuvants used, I will give the choices. The adjuvants used are phenol, hydrogen dioxide, liquid nitrogen, hydrogen peroxide, argon beam laser. What is the most commonly used adjuvant? What is the best adjuvant?
Best adjuvant is liquid nitrogen.
Wrong. So most commonly used is phenol, best is argon beam laser. It is given in Campbell. Okay, go and read. So any other, okay, coming to Veeramani, any other drugs you will give or any pharmacotherapy for giant cell aneurysmal bone cyst?
I don't know, sir.
Okay.
Sir?
Sir, Kumar sir, you want to add? Sir, you can give IV zoledronic acid. Zoledronic acid can be given.
Sir, any role for denosumab injection, sir?
Donosumab also you can give. Donosumab you can give. Bisphosphonates you can give. Pharmacotherapy also should. Donosumab also accepted. Sir, Kumar sir, you want to add, sir, or you want to ask anything?
Yeah, I want to tell about. He told that adjuvants means that is used for killing the residual tumor cells. That is a microscopic tumor cells also will because we are doing intralesional curettage. Even in the marginal curettage also there will be some malignant or some tumor cells will be left out. So we will cure with the adjuvants. That is called adjuvants. We are giving adjuvant to curettage. So that will prevent the recurrent rate. Okay. As he told, the treatment is ideal treatment is depends on the surgeons. We can use a bone cement or a graft.
Okay. So the 7 points: age is relatively immature, location proximal tibia, metaphysis, eccentric expansion, tumor margin, you can say well defined, pattern of bone dissection, geographic, lytic, Periosteal reaction, there is some periosteal reaction accepted. Matrix is clear. Complication as of now, no. So age group is 10 to 20 years, more common in females. MRI is double density fluid level. So this is the double density fluid level in MRI. Okay. MRI of aneurysmal bone cyst. So next we will call Vishal. Vishal. You can read the question
Vishal.
and answer, and you can answer.
Sir,
Vishal, are you
yes,
there?
sir. Sir, this is a plain X-ray of a skeletally mature individual showing the phalanges with the lytic lesion.
Whether it is in the metaphysics or if it is like location, you tell the location, man.
Sir, in the epiphysis, sir. Epiphysis metaphyseal junction, sir.
Okay, good.
Without
It's
periosteal
not
reaction.
epiphysis metaphysis junction. It's epiphysis or metaphysis.
Even diaphysis.
Fully, if it is organized fully. Okay.
Okay, sir. With the stippled calcifications in the bone matrix.
Okay.
Probably enchondroma of the phalanges.
What is any periods? You have to read, tell all
the 7 points you should say.
You got to, margins. What about the margin?
Well-defined margin, sir, which indicates a benign tumor.
Very good. Okay, well-defined margin. Then
no periosteal reaction, sir. In the bone matrix.
Is it central or eccentric?
Central, sir.
Vishal Ravi, you follow the order. You write, you side by side, all the pages, you write the 7 points. You follow the order, it will be very easy. No need to confuse. You don't go here and there. We don't want the diagnosis. You should know how to read the X-ray. That is the thing.
That's the
main point of.
Don't follow the 7 points you told means. You follow this means you will be very familiar to that. Every time you go, you will read the 7 points. First, age. Repeat, Vishal. Start from age.
Plain X-ray of a skeletally mature individual showing the phalanges and the lytic lesion in the epiphysis and metaphysis. Centrally placed lytic lesion with the well-defined borders and no periosteal reaction. The stippled calcification in the bone matrix without any calcification. Probably my diagnosis is
why you say without any calcification? Stippled means it is calcified it is calcified area only. You cannot say without any calcification. You cannot say you forgot to say it is a geographic type of lesion. Okay. Without any complications, most probably a benign bone tumor.
Okay, sir.
After that, you should say the diagnosis is.
Also, you have to add no complications. No, you have to tell whether there is any intra-articular extension. So it may be pathological fractures or intra-articular extension. Always we will be very well interested in knowing whether it is intra-articular extension of the tumor or cortical breach. These two words, and also if you don't know the cortical erosion or pathological fractures like that, you got the treatment is differs. There is any articular extension or if there is any pathological fractures. Okay, you got to last point. You got to always have any complications. If there is a complication, you got to tell it. Okay. Now we go for diagnosis.
So I want to say, when you are asked to read the X-ray, you don't say no complication. Don't say like that. You should say there is. You have read all the things. The examiner asks any other thing you want to add. You can say there is no pathological fracture, no cortical breach, or no soft tissue extension. If it is, okay. So what are the syndromes associated with multiple lesions? These are all additional questions for your asking. Yes, Vishal. You know,
sir, Maffucci syndrome due to multiple enchondromas.
Okay. Half correct, only half mark. If you have C 1 mark, you will get half mark, another half mark. Another answer. Anybody in the PG's panel? Anybody can answer.
Olier's syndrome, sir.
What is the difference between Olier's disease and Maffucci?
Sir, Olier's syndrome is having multiple enchondromas.
Okay.
Maffucci syndrome associated soft tissue angioma might be present, sir, which has 100% malignant transformation chances present.
So in Maffucci, it is Olier's disease. It is multiple osteochondroma alone. In Maffucci, it is multiple osteochondroma. That is Olier's disease plus soft tissue hemangioma plus phlebolith. These three things are there. Okay. Okay. Complications, Vishal. Enchondroma complication. What is the complication? He told.
Pathological fracture, sir.
Very good. Then another complication, important complication. He told now.
We can convert into malignant.
What malignancy?
Chondrosarcomas.
Okay. Treatment.
Sir, if asymptomatic, it can be left conservative.
See, we are talking about this. Okay. Since only X-ray is there, you are saying asymptomatic. Okay. Okay.
Sir,
but
extended
this type of lesion,
intralesional curettage.
What your answer is? Curettage, intralesional curettage, not enough. Not enough.
You always use, now only we discussed about the extended session.
Extended intralesional curettage.
No, don't use
bone graft.
That use only the extended curettage. That's enough. Okay. Use the word extended curettage for enchondromas or even for the aneurysmal bulges and giant tumor.
So I'll give the mnemonic for extend. I'll give the mnemonic. If you want, you can take down. Extended curettage is indicated in all the following 4 tumors. The tumors are chondroblastoma, aneurysmal bones, giant cell tumor, enchondroma. The mnemonic is CAGE. CAGE. CAGE is the mnemonic for tumors treated by extended curettage. Chondroblastoma, aneurysmal bones, G for giant cell tumor, E for enchondroma. All these tumors, treatment of choice. Treatment of choice means you should say only one treatment. You cannot say 1 by 1, 2 or 3 treatments. You cannot say. This extended curettage and if necessary bone grafting. Okay. So skeletally mature, proximal phalanx, central tumor margin well defined, pattern of bone destruction, geographic, no periosteal reaction. Matrix is chondroid. It is flocculent. You can also say stippled. That is not a problem. Stippled, flocculent, you can interchange. The thing is, you should know it is a cartilage producing tumor. So cartilage means calcium deposition. It will be seen as a sclerotic lesion in the lytic lesion. That is very important. Okay, sclerotic dots in the lytic lesion. That is the chondroid matrix is the sclerotic. The lesion is the lytic. Okay, complication nil. Syndromes associated Olier's disease and Maffucci. Complication malignancy and pathological fracture. Treatment extended curettage and plus or minus bone grafting. This is Olier's disease. So if you see this, there are multiple enchondroma present over all the metacarpals, all the proximal phalanxes. Maffucci syndrome, in addition to that, you see them some dots. That is the phlebolith. That is nothing but phlebolith. Hemangioma you cannot see. That is the phlebolith. Okay, how you can remember these two? So Olier's disease, O for O, only enchondromatosis. O means O for Olier's and only enchondromatosis. If only enchondromatosis means only enchondromatosis, it is Olier's. Multiple, Maffucci, M for multiple. Multiple, that is 3 things are there. Multiple enchondromatosis. Second one is soft tissue hemangioma. Third one is phlebolith. So multiple findings are there, means it is Maffucci syndrome. Okay. So we have finished Veeramani and Vishal over. Next we will call Gautam. Gautam.
Yes, sir.
Read the X-ray.
Skeletally immature patient here. So showing plain X-ray of knee joint, location of the lesion, proximal tibia and proximal fibula, and distal femur also location of lesion is present, sir. Margins are
Before going to that location, you finished up one more thing, no? Whether it is in the metaphysics or
image X-ray. So involving the locations involving the metaphysis of the proximal tibia, the metaphysis of fibula, and the metaphysis of distal femur. Margins are well defined in APU in a proximal tibia. Pattern is a geographic pattern, sir. There is a matrix of the lesion is clear.
Either you don't know periosteal reaction whether it is present or not.
It's a solid periosteal reaction.
Solid periosteal reaction. Where?
The matrix is LYTIC, sir.
Okay.
Is eccentrically placed LYTIC lesion. I will
is there any clue regarding there is a clue regarding the distal end of femur? What has happened to the distal end of femur? So it is not like you can, since you want to say eccentric LYTIC lesion, only you are concentrating only on this alone. Okay. Okay, see this, you have to see as a whole only. Here, you have to see as a whole only. Yes, I don't know whether you know the diagnosis or not. It is a skeletally immature patient.
The diagnosis.
Sir?
He didn't told the diagnosis.
Okay.
diagnosis.
The metaphysis. What happened to the metaphysis? Shape. He asked something about the shape of the metaphysis. It's a normal shape.
Sir, I will go for a differential non-ossifying fibroma. It's a chondromyxoid fibroma. Down's tumor of parathyroid.
Okay, leave it. You are saying the diagnosis for LYTIC lesion alone. You are saying the diagnosis. It is actually not the LYTIC lesion. This X-ray, the photo has been taken like that. It does not come under that LYTIC and sclerotic is there. No, here it is it will come under bone forming tumor. It is cartilage forming. It is a chondroid matrix is there. You leave that LYTIC. You say what happened to that femur metaphysis. Metaphysis has been widened. You are able to appreciate. So what are the lesions you should see here? Here there is one lateral aspect. There is one tumor. Okay, there is one bone forming tumor. Cartilage. Here the lateral and posterior aspect there is a tumor, and the metaphysis broadening of the metaphysis is there, and another tumor in the medial aspect, anteromedial aspect, another tumor, and another tumor in the lateral aspect of, fibula. So there are multiple tumors with widened metaphysis of a skeletally immature patient. Now you say the diagnosis. It is a very different, it is a very common tumor which you need not see all the 7 findings. These are the clues to the diagnosis.
Is it a single tumor or multiple tumor? Gautam?
There's a multiple tumors.
What are the multiple tumors? Benign tumors, he told.
There is a distal femur.
Sorry, okay, we can ask some other. Madan, can you say the diagnosis? Madan.
Sir, osteochondroma, sir. Exostosis.
Yes, you say complete diagnosis.
Skeletally immature. X-ray. So location. Distal femur metaphysis and proximal tibial and proximal fibular metaphyseal area. Tumor margins are well defined. Osteolytic type of bone destruction.
But then he wants the diagnosis. Sir wants the diagnosis.
Go to the diagnosis.
Osteochondroma.
Diagnosis is multiple exostosis. Why are you not
Multiple
saying
exostosis.
multiple exostosis? Even multiple exostosis is not enough. You should say MHE. What is MHE? After seeing the femur, you should say MHE. The diagnosis is MHE. What is that MHE, Madan?
Hereditary exostosis.
Multiple hereditary exostosis.
Hereditary exostosis. Okay. What is that widening of the femur? What is that deformity called?
Erlenmeyer flap deformity, sir. Erlenmeyer flap deformity.
No. It is not Erlenmeyer. I cannot accept it. Anybody in the PG, anybody can say. What is that called? This class, this was taken by Professor Balachandra, sir. I have attended all the programs. So it is actually like repeat only. He told when the tumor session was there, he told the finding. So it is not a simple tumor. It is a developmental dysplasia of bone. Okay. It is not. We are not talking about solitary osteochondroma. It is multiple hereditary exostosis. So it comes under developmental dysplasia of bone. It is a very problem in the remodeling of the distal femur or the knee joint. So if the patient is presenting with multiple hereditary exostosis, even with a single X-ray, if you want to diagnose, you should take the X-ray of the knee joint. The answer is, the name of the deformity is trumpeting of the distal femur metaphysis. Okay. The next, the other questions we'll come to Gautam. Name 2 signs of malignancy. Now the diagnosis, you know.
It's multiple.
2 signs of malignancy in osteochondroma. Yes, we come to
Osteosarcomas.
He is asking when you suspect what are the symptoms or signs of
malignancy.
Signs of increase in size, increase in pain, and pattern. Increase in margins, increase in size of the lesion, sir. Then margin will be.
Okay, Gautam, it's not clear. Gautam, you leave it. We will ask Madan.
Sir,
what are the signs of malignancy
calcification,
in osteochondroma? It is a very important example.
Calcification of cartilaginous cap. Calcification of cartilaginous cap. Increased growth after skeletal maturity.
Okay.
And pain, sir.
Pain. So it is
more than 2
pain
centimeters.
Okay.
What are the symptoms?
So what are the?
Sir?
Okay, Madan, you complete. What are the complications?
Sir, complications, nerve compression, bursitis.
Okay, accepted.
Malignant transformation.
Okay, okay. Okay, if you say 3, okay, what is the treatment?
Extra periosteal excision.
So you should not, when we ask treatment, you should not say, since you know extra periosteal excision, you cannot say like that. So you have to say whether it is symptomatic or asymptomatic. You cannot do extra periosteal excision for all the tumors. You should say specifically, sir, if it is asymptomatic, what is the treatment?
Asymptomatic, no, only conservative treatment.
No treatment. Okay, observation. If
No
it is
treatment.
symptomatic only, you will do extra periosteal excision.
Yes, sir.
Extra periosteal
Excision, sir.
resection or excision.
Resection.
Why you want to do extra periosteal? What are the theories of osteochondroma?
Recurrence. Recurrence will reduce the extra periosteal reaction. Excision.
Sir, Kumar sir, you want to ask?
What is the basic defect in this? What is the cause for the trumpet shape is? What is the cause for the trumpet shape? Here, where is the defect? The defect is the metaphyseal remodeling defect. Okay, wow. It is a metaphyseal remodeling defect. One of the cause for the trumpet shape is metaphyseal remodeling defect in a multiple hereditary exostosis. I want to ask one more question.
Okay, sir.
How do you estimate what is the investigation choice for measuring the cartilaginous thickness or cartilaginous cap?
MRI.
How do you, when you
MRI.
you can suspect how much is normal? When you suspect
More than 2 centimeters is malignant. Sir. More than 2 centimeters.
More than 2
centimeters
centimeters?
malignant. Malignant.
Okay. So more than 2 centimeters of cartilage thickness, it is a malignant. If it is between 1 to 2 centimeters means
Borderline.
the borderline suspicious of malignant transformation. Less than 1 is normal. Okay. Okay. The treatment
Sir,
also
I want to
always because make aware deformity. Multiple exercises to patients may also give upper limb commonly in the forearm deformities may be there. And the deformity correction. Otherwise, only the symptomatic tumors only you have to be removed. And we have to tell the patient about the warning signs of malignancy. Even in the exam, if you given a case of multiple exostosis, I will give the warning signs to the patient, whether there is increase in size of tumor even after skeletal maturity or any sudden increase in pain and pathological fractures.
Sir, one thing about that cartilaginous thickness cap. So I think the best investigation will be CT, sir. For CT will be giving the cartilaginous thickness cap. CT will be more. MRI also you can find, but CT is more specific for, especially for cartilaginous thickness. Only in few places in bone tumor where we take CT is to see the thickness of this. Other one is osteoid osteoma. Also CT is the investigation of. Right. Okay, sir. Okay. So it is multiple exostosis, trumpet-shaped deformity, rapid increase in size, unexplained pain, complication, bursitis, impingement of soft tissues, malignant transformation. Yes, what type of malignancy you will get? Gautam, you answer this one. What type of malignant transformation you get in osteochondroma?
Osteosarcoma.
So you are wrong. So it is not osteosarcoma. The more common is
chondrosarcoma.
So you should remember osteochondroma. First itself, I put that classification slide only for that. Classification, WHO classification slide I put only for that. Osteochondroma is a cartilage forming tumor. Okay. So asymptomatic, no treatment. Symptomatic, extra periosteal excision or resection. Sir, can we go to the next one, sir?
Yes, you can go for it.
So we will call Salman Khan.
Good evening.
Good evening. So your video is on.
Yes, sir.
Okay.
The plain X-ray of a skeletally mature patient showing lytic lesion in the proximal tibia, eccentric in location, involving epiphysis with metaphyseal extension. Margins are well defined with a geographic type of bone destruction with no periosteal reaction, lytic matrix, clear matrix with no complications, suggestive of osteoclastoma or aneurysmal bone cyst or a non-ossifying fibroma.
First diagnosis?
Giant cell tumors.
Okay, you left only one thing. Other things you are right. You told it is eccentric. It is eccentric expansile lytic lesion. Okay, so you should remember this giant cell tumor. It is a one tumor which can go up to the joint, can go up to the subchondral bone. Okay, can go up to the subchondral bone. X-ray findings right, diagnosis right, grading.
Radiological grading. He's asking radiological grading. What type of radiological grading?
Campinassi grading.
Very good. You know that even if you say the name, it is enough. Okay, Campinassi, very good. Anything, any staging? How many types?
Stage.
Yes.
Any king stage.
What are the types? In any king, what is this type? Please you tell this. Any king for benign tumor? Tell me. What are the three stages? Three types.
Yes, you are right. Be louder. You are right.
And if you come to the exam, you have to be a little more aggressive. Tell me. What are the
Sir told the answer.
Latent, active, and aggressive.
That is generally for any king stage benign tumor. That giant cell tumor comes under
aggressive tumor, sir.
Aggressive tumor. Okay. So what is the treatment?
Extended curettage.
It is not complete. Answer is not complete.
Extended curettage with augmentation with bone cements.
Or
bone graft.
So for all extended curettage, you have to add bone graft if it is necessary. Okay. Any other technique? You know what is sandwich technique? You know or don't know? Anybody? Anybody can answer. What is sandwich technique in the treatment of giant cell tumor? Especially for this lesion. This lesion you can use that. This tumor is extending up to the articular surface. Anybody can say what is sandwich technique? Yes, Veeramani, Madan, Vishal, Uday Kumar, anybody can answer.
Sir, near the joint surface, we'll do bone grafting, sir.
Very good.
Along with bone cement in the rest of it.
Okay, what do you mean by sandwich? In between the bread slices, you will have that vegetarian.
Gel foam is there, sir. Gel foam between the bone graft and there is gel foam is there, sir.
Sir, very good. What is the advantage? Why we want to use that gel foam? What is the advantage?
Sir,
why?
This above is bone grafting. In between gel foam and here is the cement, sir. They destroy the cartilage reaction. Cartilage will be preserved, sir.
The heat generated from the bone cement
will not transfer into the bone graft, sir. The cement will not transfer. Heat will not transfer into the bone graft, sir.
So that is called the sandwich technique. We use gel foam. Okay. So for giant cell tumor also we have divided Campinassi 3 grades are there. Ennicking also separate classification is there. Okay, Campinassi grading. See, grade 1 is well defined. Usually giant cell tumor will not have sclerosis. But if it is a very mild grade 1 is well-defined lesion with sclerosis may be there. Grade 2 is relatively well-defined margin, then no sclerosis, and the cortex is thinned out and expanded. Grade 3 is ill-defined margin, cortical destruction and soft tissue extension. In this, if the grade is 3, here it is latent, active, aggressive. In grade same latent, you will have a lytic lesion. Here you will have pathological fracture. In active stage, you can have pathological fracture. In aggressive stage, you can have pathological fracture, cortical breach, and also soft tissue extension. The treatment for active and aggressive or grade 3 giant cell tumor is wide surgical excision with prosthesis, with reconstruction. Okay, that is the treatment for grade 3 giant cell tumor. You should remember that also. You should remember. So diagnose giant cell tumor, grading, capillary grading, ending stage, and complication, recurrence, and giant cell tumor is one of the more common tumor for recurrence. Okay, treatment of choice is extended curettage and bone grafting. Sir, if you want to add, you can add some points. Otherwise,
now I am. Anyone say what is the pharmacotherapy for giant cell tumor?
Denosumab, sir. Denosumab, sir.
Okay, denosumab is very useful for
to reducing the tumors, reducing the tumor size.
Okay, it can be treatment as they are using only the denosumab to decrease the tumor size, and then the only treatment for that. Next is they use this for to prevent the recurrence of the tumors. For recurrent GCT and to prevent the recurrent GCT also, they are using the denosumab. That is very useful drugs. Okay, somebody also used the zoledronic acid. They also tried the zoledronic. It's also useful for the treatment of giant cell tumor. Okay.
So you can remember giant cell tumor and aneurysmal bone cyst both similar in location. Even if preoperatively, if you diagnose in the biopsy, the diagnosis can change. Both can interchange. Both are interchangeable. You should remember that. You never forget.
Both two are locally aggressive tumor. Locally aggressive tumor. You have to think in the treatment in that line. Okay, if there is any intra-articular extension, what will you do? Anybody in the group? Anybody? If there is any intra-articular extension or any associated with the pathological effect, what will you do? Gautam, Vishal, anybody? So if there is any pathological fractures or intra-articular extension, you have to go for arthroplasty. Usually you use a custom mega prosthesis using replacement surgery.
It is advanced.
Mega prosthesis.
So it will be like malignant treatment, treat like malignant bone tumor.
So shall we go for next case?
Okay, sir. So next we will call Uday Kumar. A simple diagnosis. You go by the order.
Sir, good evening, sir.
Good evening.
This is an X-ray of a plain X-ray of a skeletally mature individual showing X-ray pelvis AP view, sir. There's the location of the tumor is on left ilium bones. It seems to be a sclerotic tumor, sir.
Okay.
And tumor margins are ill-defined, sir.
Very good.
And the matrix seems to be have multiple ossifications present.
So what type of what matrix, osteoid or chondroid?
Since the matrix seems to be a flocculent chondroid type of matrix, sir.
Very good. Flocculent.
And periosteal reaction cannot be.
Okay.
Should be probably a case of chondrosarcoma.
So this is called a popcorn calcification. Popcorn calcification. So your diagnosis is chondrosarcoma. Any other differential diagnosis? Another chondroid producing tumor, enchondroma also.
Enchondroma.
Okay. So chondrosarcoma is correct. So what are the types of chondrosarcoma? What are the types? What are the types of osteosarcoma? Same answer for chondrosarcoma.
Sir, for osteosarcoma, we have high-grade intramedullary, low-grade intramedullary, periosteal, parosteal, small cell and telangiectatic.
Okay. Types of chondrosarcoma. Very simple. Based on the age group or else, or based on the age group. The types are, anybody? You can answer.
Conventional.
Okay, I meant only primary and secondary. Okay, primary you will get in more age group, more than 40 to 45. Secondary, from any other tumors like enchondroma, osteochondroma, you can get in still younger age. Okay, so what is the treatment for chondrosarcoma? What is the treatment of choice for chondrosarcoma?
For malignant, there's only 3 options, man. What will you
do? Chemotherapy.
Whether it is sensitive to chemotherapy or.
Sir, I think he is thinking since it is in the ileum, it is difficult to do surgery. I think he is thinking in that.
That's right. Whether the chondroid tumor sensitive to chemotherapy or radiotherapy, man?
No, sir.
So it is not a
surgical excision.
So the option is
surgical excision.
So it is not simple surgical excision, it is wide surgical excision.
Yes,
what
sir.
is that? Wide means how many centimeter you will remove?
2 centimeter.
2 centimeter of margin from normal tissue can be there.
So 2 centimeter or 3 centimeter. Okay. Sir, you want to add or I go to the answers, sir?
Okay. Okay. Next case will go.
So it is a skeletally mature patient with a sclerotic lesion in the pelvis, borders ill-defined, pattern of bone destruction, sclerotic, periosteal reaction nil, matrix is chondroid, flocculent, complication, there is no pathological fracture. So complication nil. Diagnosis types primary and secondary. Treatment is wide surgical excision. Okay. So we will call Bharat. Bharat Irgara. Bharat.
Yes, sir. Yes, sir.
Bharat,
Good evening,
you can
sir.
try this. Good evening.
Yes, sir. This is a plain X-ray of skeletally immature patient, showing knee joint, AP and lateral views.
Proceed.
Yes,
Proceed
sir.
one by one. You say what is that?
Yes, sir.
Okay.
Location is centrally located. The lesion is with ill-defined margins.
Wait, Bharat. You told age skeletally immature. Okay, you can say the basis line is somewhat seen. Okay, location. You didn't say location. What is the location?
In the metaphysical region.
Metaphysics of the.
So anyway, all should always says horizontal alignment in the vertical and the horizontal. Yeah, then one will tell that both. You have to tell both, whether it is central or eccentric or cortical. Ademe metaphysis, epiphysis, or diaphysis. You have to tell like that. Okay. All remember this. Proceed.
Location is a metaphysical epiphyseal region, sir.
It is not epiphysis, only metaphysis. You are right.
Metaphysis, diaphysis.
Can say diaphysis. Epiphysis is not involved here. Okay.
The lesion is ill-defined borders.
Ill-defined border. Type of lesion, pattern of bone destruction.
Sir, MOTH-EATEN pattern.
See, you didn't follow the class. We have divided that into lytic and sclerotic. Okay.
Yes, sir. This is
you remember that. So it is lytic means it is radiolucent. Very, very simple. Lytic means radiolucent, dark color. Sclerotic means what to say? White color, white in color, plastic lesion. So it is white in color, or radiolucent or a plastic type. What is that?
Plastic type.
என்ன தரா விட்டுனா பைக்ல போனாங்கல்ல, ஆடும் இல்ல கேஷுவல் இல்ல, ஒண்ணுமே இல்லாம வெறுமன போனேன். செலவு இருக்காது நம்பிக்கைடா. வண்டி பஞ்சர் ஆச்சுன்னு வச்சுக்க.
Yes, there is some disturbance.
Okay,
கௌதம் சொல்லுங்க, என்ன ஸ்க்ளீரோட்டிக்கா லைட்டிக்கா என்ன சொல்ல வரீங்க இப்போ?
Sclerotic lesion.
Okay, then borders ill-defined, you told.
Ill-defined borders, sir.
Okay, அடுத்து போங்க. அடுத்து இன்னும் என்ன இருக்கு? அடுத்து periosteal
reaction. Yes, sir. Periosteal reaction seen, sir. So malignant type of periosteal reaction.
என்னெல்லாம் தெரியுது உங்களுக்கு? periosteal reaction.
So interrupted one, sir.
Okay, periosteal reaction over matrix.
Osteoid matrix, sir.
Osteoidல என்ன டைப்? 3 டைப் சொன்னேன் நான். Solid cloud like ivory like solid
ivory like
cloud like ivory like
cloud like
okay, ivory like, right? Okay,
ivory
like accepted. Complication எதனா இருக்கா?
Periosteal reaction, sir.
Complication.
No cortical break, sir. Periosteal reaction seen, sir. No pathological fractures.
No pathological. Good.
No pathological fracture. Okay. Cortical breach, I think cortical breach.
Yes, sir. Cortical breach seen, sir. Periosteal reaction.
You told that cortical breach.
So what is your diagnosis? Benign or malignant tumor?
So it's based on the findings. It's a malignant tumor.
So you want to give diagnosis or differential diagnosis?
Sir, I want to give a differential diagnosis.
Okay,
based on the location, based on the skeletal image pattern, seems to be a osteosarcoma, sir, in the distal femur region.
Very good. Osteosarcoma diagnosis everyone knows. Okay, so then you should say what is the treatment of choice for osteosarcoma? We are talking about what are the types of osteosarcoma? WHO classification, or what are the types? Okay, I think that is not included in this class, so you are finding difficult. We'll leave that. So at least
next, read the nearby X-ray also. Read that nearby X-ray.
What has been done for this? For this highly malignant osteosarcoma of the distal femur, what they have done? They have done a
wide resection and the prosthesis.
Wide surgical resection, reconstruction with the prosthesis. What is the name of this prosthesis? You know or don't know? We will call somebody.
Don't know, sir. Sir, okay. I don't know.
Okay, anybody in the PG panel group, you can answer this.
Custom mega process has been used.
Okay, custom mega processes. Okay, so who is the pioneer in Tamil Nadu? Who is doing this?
Mailvanan Nadarajan, sir. Mailvanan.
Yes, Professor. You have to say Professor Mailvanan Nadarajan. Okay, so Bharat, you know the chemotherapy regime for osteosarcoma? Anybody can answer. Chemotherapy regime for osteosarcoma.
Sir, doxorubicin, cisplatin, high-dose methotrexate, and ifosfamide can be used.
Very good. The mnemonic is You can remember like this. The mnemonic is mica, high mica, 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 high dose methotrexate, ifosfamide, cisplatin, adriamycin, or doxorubicin. So the treatment of choice for osteosarcoma is, you should say, if it is a primary conventional type. Okay, the treatment of choice is neoadjuvant chemotherapy, followed by wide surgical excision and reconstruction, followed by adjuvant chemotherapy. So you should say all these three things. That is the treatment of choice for high grade conventional osteosarcoma. Sir, can we go to the answer slide, or you want to?
Let's to proceed to the answer sheet.
First mega process. So osteosarcoma is a very important topic. You read. Periosteal reaction, it is a speculated type. You didn't say interrupted la speculated type. கொஞ்சம் sunburst appearance தெரியதான் செய்யுது. Okay. Okay. So till only 2 more slides. So I am not having the lateral view. We will call remaining Jenny Jose. Okay, Bharat, thank you. You will call Jenny Jose. Your video should be.
Sir, X-ray shows lesion over the diaphysis of tibia. It is immature skeleton, and the margins are ill-defined. Periosteal reaction is of lamellar type.
Your video is not coming.
Sir.
Chennai Jose. You are from which college?
Sir, Coimbatore Medical College.
Proceed, no?
Sir, X-ray shows LYTIC lesion over the diaphysis of tibia in an immature skeleton with periosteal reaction of lamellar type. Diagnosis probably
wait. Diagnosis everyone knows. We don't want the diagnosis. Diagnosis everyone knows. Okay, you go. You say all the 7 points. That is the aim of this class. Other answers, if you are not saying, no problem. That 7 points you should try to say no. So you told skeletally immature patient. What type of lesion you are seeing? Lytic or sclerotic?
Sir, alternating, sir, lytic and sclerotic.
Sclerosis, what you are seeing is the type of periosteal reaction.
Okay,
so what to say? It is the lesion you cannot identify. Then means what is that? Ill-defined border, you told. Ill-defined border. So what is the 3 types of lesion you have seen? Geographic, moth-eaten, and permeative. In that, which one you can say?
The permeative, sir.
Yes, that's the thing we want. That is the thing we want. It is a permeative lesion. You see here, some lysis is there. It is a permeative lesion with ill-defined border. What type of periosteal reaction? You told lamellated, accepted. It is a malignant type of aggressive or malignant type of periosteal reaction. So lamellated appearance, okay, accepted. And then matrix, it is a matrix, you will not comment. Okay. Then any complication you are seeing. So as if you give an X-ray is given, you should not only see the bones, you should also see the soft tissue. Able to see some huge swelling is there. Able to see.
Yes, sir.
So soft tissue mass is there. Soft tissue mass is there. Now you say all the 7 points and say the diagnosis.
Sir, immature skeleton showing lesion over the diaphysis of the bone with ill-defined margins and wide zone of transition, and showing permeative type of bone destruction with the laminated periosteal reaction with the clear matrix and complication. It is extending into the soft tissue.
Okay. So now your diagnosis.
Probably even sarcoma.
Ewing sarcoma accepted. Differential diagnosis.
Multiple myeloma is old age multiple myeloma secondary metastasis.
You cannot say whatever you know.
Simple one.
Important differential diagnosis of Ewing sarcoma. The clue is child.
LCH.
Ewing sarcoma is a tumor in which the fever may be present. Okay.
Sir, osteomyelitis.
Very good. Osteomyelitis is the important differential diagnosis. Other diagnosis in respect to tumors, any other tumor you can say.
Simple bone.
Malignant tumor.
Adamantinum.
Adamantinum. It is osteosarcoma. Why you are not saying osteosarcoma? It is also a malignant lesion. Okay.
Periosteal reaction.
Yes, periosteal reaction. I told you all the type of malignant periosteal reaction, whatever it may be, sunburst, Codman's triangle, and onion pin. All these three things can be seen in any chronic or any malignant bone tumor or chronic infections. Okay. So main differential diagnosis is osteomyelitis. Second differential diagnosis is osteosarcoma. The only thing against osteosarcoma is it is a diaphyseal lesion. Osteosarcoma, you should read about the subtypes. Subtypes there are osteoblastic, chondroblastic, fibroblastic, telangiectatic. So all types of lesions are lytic lesion, sclerotic lesion, lytic mixed with sclerotic. All the types you can see in osteosarcoma. So what is now? So okay, different Ewing sarcoma diagnosis accepted. What is the treatment of choice for Ewing sarcoma?
There are chemotherapy and surgical resection.
So if I ask treatment, you should say the treatment of choice. You should say complete.
Yes, sir. Sir, chemotherapy.
So you want to say chemotherapy is the treatment of choice for Ewing sarcoma.
Extended curitage.
Yes, that is your answer. That is the wrong answer. Anybody? Only I told. Anybody? It is a high
Extended curatage with the bone graft.
Oh, no.
Radiotherapy, sir.
Neoadjuvant chemotherapy. Hello. Sir, neoadjuvant chemotherapy with limb salvage surgery.
Neoadjuvant chemotherapy, then
Chemotherapy.
Followed by limb salvage surgery if possible to resect the tumor, sir, or else tumor can be done a wide excision, sir.
Okay.
And then again, chemotherapy can be continued for 6 to 12 months. Sir.
Okay.
Role of radiotherapy?
The radiotherapy can be given, sir, but not always given.
No use of radiotherapy.
You are right. In Robbins, there is a word. Ewing sarcoma melts like snow. Melts like snow. Like snow, it melts by radiotherapy. But radiotherapy is not the treatment of choice. Okay. You should know it is one of the, most radiosensitive bone tumor is Ewing sarcoma accepted. But radiotherapy is not the treatment of choice. Treatment of choice, if you ask, you should say, sir, it is neoadjuvant chemotherapy followed by limb salvage like wide surgical excision and reconstruction, followed by adjuvant chemotherapy plus or minus radiotherapy. If we want to give, we can give plus or minus radiotherapy. But osteosarcoma is a radio-resistant tumor. Chondrosarcoma is a radio-resistant tumor. Okay, it should be clear. Okay, can anyone say what is the chemotherapy drugs regimen we are using for
VAC regimen, sir.
Okay, what is that?
Vincristine, adriamycin, cyclophosphamide.
So it is not cyclophosphamide. Recently we ifosfamide. So ifosfamide, vincristine, doxorubicin can use. Sir, you want to add, sir? Kumar, sir?
Okay, sir. Proceed.
Jenny Jose, you say Ewing sarcoma comes under marrow tumor or round cell tumors. What are the other marrow tumors you know? Questions from the class.
Sir, marrow tumors, Ewing sarcoma, multiple myeloma, plasmacytoma, secondary metastasis.
Secondary metastasis. This lymphoma. Okay. So skeletally immature tibia diaphysis, ill-defined, herniative, lamellated, matrix nil, soft tissue mass is there. Having sarcoma, osteomyelitis and osteosarcoma, neo-adjuvant chemotherapy, surgery, adjuvant chemotherapy, plus or minus radiotherapy. Okay. They're coming to the last slide, simple slide. The person left is Suresh Lakshmi. We started with the Suresh, we will finish with the Suresh, sir. So both are different areas, but same diagnosis. Okay, Suresh, are you there? Suresh Ilana, anybody can volunteer and say read the X-ray. Last X-ray, we'll finish.
Uday Kumar la Gautam.
Uday Kumar, Gautam, Vishal, anybody can answer.
Sir, sir, good evening, sir. Sir, this seems to be an X-ray of shoulder as well as knee joint of a skeletally immature child, sir, showing a tumor located in the epiphyseal region, sir.
Very good.
The knee joint, the lesion seems to be lytic and well defined with a sclerosed margin, sir.
Very good.
In the shoulder, it is ill-defined and flocculent deposits are present.
Okay. Okay, accepted. We will concentrate on the shoulder. Shoulder first, we will finish.
Yes, sir. There seems to be a wide zone of transition, sir. And periosteal reactions are not very much evident, sir.
Okay.
And no pathological fracture or cortical breach, sir. Could be a case of chondroblastoma, sir.
So chondroblastoma is suddenly you are saying chondroblastoma. Chondroblastoma is a benign tumor or malignant tumor?
It's a benign tumor, sir.
Then you are saying wide zone of transition and periosteal, I think you told some. So I don't think it is wide zone of transition. It is clear only. Why you are saying wide? So skeletally immature, epiphysis, proximal humerus, borders, you can say relatively well defined. It is not ill defined, relatively well defined. Next point is periosteal reaction nil. It is a geographic type of lytic lesion with flocculent. So it is a chondroid producing tumor. Flocculent chondroid matrix with no complications. Now your diagnosis is chondroblastoma. Okay. What is the other name for chondroblastoma? Anybody?
Codman's tumor.
Yes, it is called Codman's tumor. First diagnosed by Codman. What is the special name of the calcification in Codman's tumor?
Cobblestone and chicken calcification.
Yes, yes. Somebody told the answer.
Untitled calcification.
No, I didn't get it.
Cobblestone or chicken.
Yes, it is called chicken wire calcification. Chicken wire calcification is nothing but the chondroid matrix with pericellular calcification. Chondroid matrix with the pericellular calcification is the chicken wire calcification. What is the treatment for chondroblastoma?
Extended intralesional curettage with bone grafting.
So extended curettage. Okay, it is a benign lesion. So extended curettage. Sir, Suresh sir, you want to add, sir? Kumar sir, you want to add something? I think
before epiphyseal fusion, if there is epiphyseal tumor, means common diagnosis is a chondroblastoma. If it occurs after epiphyseal fusion, is giant cell tumor. You have to remember like that. Okay, treatment more or less the same like that of giant cell tumor. Okay.
Other closest differential diagnosis, you can say even clear cell chondrosarcoma. Calcification, epiphysis, clear cell chondrosarcoma, you can say. Treatment is Sir, I think we can. I have finished, sir. Anything, sir, you want to add? You can add.
So, students, as a PG students, you remember these 7 points means you will never forget in your exams, no? So you got to follow the age, location of the tumor. It will be in the horizontal and vertical direction, and tumor margins and patterns of bone destruction, periosteal reaction, matrix, and complications. You read all the 7 points means you will not miss anything. Then if you read this in this pattern means the examiners will be very happy. They know that you read well and you are following some protocols to read the x-rays of tumors. They will accept your diagnosis, and it will be very useful for the treatment also. So don't always follow these things. And the treatment aspect, you have to think in terms of whether you give the diagnosis, whether it's a benign tumor or malignant tumor, and the treatment for the benign tumor, then maybe a latent or active tumor or aggressive tumor, like giant tumor A, B, C, or aggressive tumor. You have to do a locally aggressive tumor like a extended curata, then bone grafting, bar, bone cement, like that. For a malignant tumors, you got to go for a surgery, chemotherapy, or radiotherapy, like that. You got to discuss in the exams. So for the treatment aspect, you will for the diagnosis for malignant tumors, you need an X-ray for the diagnosis. Clinical diagnosis for the you can give a clinical diagnosis, but before go for a biopsy, you got to take read the X-rays to confirm the diagnosis. Thank you for. I am very much. Thank you to the TNOA office bearers and the organizers, Suresh sir, Thiru sir, and Dhanapan sir. And from here, Dharmapuri Medical College, I want to congratulate all the program developers and conducting this exam in this time. Very useful to the students and also to the faculties. Not only it is useful for the students, it's also useful for the faculties. Thank you, sir. Congratulations, sir.
Thank you, sir.
Thank you, sir. I also want to thank Professor Thiru sir, Professor Dhanapan sir, and Professor Suresh Kumar sir. Hope the class was useful to you and the mnemonics was useful to you. Thank you, sir.
Sir Dhanapan sir,
I forgot to tell about the Agniraj. Agniraj presented excellently, sir. He commanded the mnemonics and also orderly. He's very useful. He's so fluent. So he is congrats to Agniraj also, sir.
Thank you, sir. Thank you, sir. I will stop share.
Okay. I profusely thank Dr. Agniraj sir for.
Sir, you can call me Agniraj itself, sir.
No issues. So for conducting this wonderful session in a very short period of time, we have given him just 3 days of time. He has prepared the topic within these 3 days, and there was a general request from the postgraduate sites to conduct a class based on OSCE pattern. So I think that pattern has been fulfilled now clearly. This is an excellent session. So thank you so much, Dr. Agniraj sir and Professor Kumar sir. We enjoyed a lot. I request the postgraduates to go and see the video again and again. So only you can learn a lot of things. Otherwise, here itself you will forget. So repeatedly you go and repeat. இதுக்கு முன்னாடி நடந்த டியூமர் செஷனையும்
ரொம்ப யூஸ்ஃபுல்லா இருக்கு. புக்கே படி தொட தேவையில்ல, புக்கே எடுக்க வேண்டாம். இது வந்திருக்க இந்த TNOA ப்ரோக்ராம் இருக்கிற எல்லா வீடியோஸ் பார்த்து you will get through the exam.
அது அந்த பழைய போன் டியூமர் செஷனின் கிளாஸையும் பார்த்து அதுக்கு மேல அப்படியே இந்த செஷனையும் பார்த்தீங்கன்னா you will become a master in reading the bone session topic and presenting a bone session topic in clinical examination. So thank you so much, sir, Kumar sir and Agniraj sir. Okay. And I also thank the TNOA president and TNOA secretary for allowing us to do this program continuously. So I also thank the academic team, Ramesh and Jayesh. We will meet on next Friday, probably the last day for our spine session. Thank you all. Good night.
Thank you, sir. Thank you so much.
Yeah. Thank you, sir. Thank you.
Also, the PGs also did a good job, sir.
Yeah.
I think it's a good experience for them also.
They did an excellent job.
To answer the exam. Yes, and I thank Kumar sir also for his, ரொம்ப பொறுமையா எல்லாத்தையும் வந்து சார் வந்து எல்லாத்தையும் வந்து கம்பைல் பண்ணி கொடுத்தாரு. So thank you Kumar sir, thank you so much.
Thank you sir, thank you sir, thank you.
தானப்பன் சார் எப்பவுமே ரொம்ப ஆக்டிவா இருப்பாரு. இந்த வாட்டி வந்து I think he was listening நினைக்கிறேன். சார் வந்து ஏதாவது ஒரு மெசேஜ்
போயிட்டு இருக்காங்க. Just I wanted to continue. It's everything is covered clearly. So basic level, fundamental level, இதோட சொல்லி தரதுக்கு வாய்ப்பே இல்லை. இன்னொரு they don't get a session like this.
Yes sir, yes sir.
He covered all the tumors sir.
Yes, எல்லாமே கவர் பண்ணாங்க. So thank you Agni, thank you once again.
Again YouTubeல பார்த்தாலும் இந்த லைவ் செஷன்ல இருக்கிற மாதிரி அந்த இன்டராக்டிவ்னஸ் கண்டிப்பா கிடைக்காது. சோ அதனால
வராது சார்.
லைவ் செஷன் வாங்க திருப்பி சொல்றோம். இத பார்த்துட்டு போய் யூடியூப் பாத்தீங்கன்னா கண்டிப்பா உங்களுக்கு நல்லா இருக்கும். டைரக்டா யூடியூப் பாத்தீங்கன்னா இந்த அளவுக்கு உங்களுக்கு கண்டிப்பா இன்டராக்டிவா இருக்காது. Thank you.
I think இன்னைக்கு தான் வந்து மேக்ஸिमम ஸ்ட்ரெngth இருந்துச்சு Agni.
ஆமா.
And the strength அப்படியே இருந்துச்சு. No, number of people they just stayed there because of the they really like the program. I think that endorses the your program.
Way of presentation, way of reaching the postgraduates. So again congratulations to postgraduates who participated. ஒரு ஸ்டேஜுக்கு வர்றதுங்கிறதே பெரிய விஷயம். இந்த சினாரியோல இதுல ஆக்டிவா பார்ட்டிசிபேட் பண்ணது very very presenting and especially a lady PG from Coimbatore Medical College.